welcome to the Dr. Julia Sen Health and Wellness podcast. I'm Dr. Julia Sen, and today I'm speaking to Miss Akshatha Ranganath. Akshatha is a consultant ophthalmologist who specialises in disorders of the retina. Akshatha, so lovely to have you here. Welcome to the clinic.
Thank you.
It's been 2 years since you joined us at the Worcestershire Acute NHS Trust Eye Department, but tell us a little bit about your background and training and what you've been doing before you came to us.
So I did my ophthalmology training in West Midlands, and I did a fellowship in medical retina at University Hospital Coventry. Along with ophthalmology, my passion is teaching. So I've done a postgraduate diploma in medical education during the time of my training. So yeah, during my training, I've traveled all over the West Midlands, worked in different hospitals. So the whole 7 to 10 years of training has really equipped me well in understanding and treating patients with eye conditions, specifically medical retina.
So, Akshatha, what was it that attracted you particularly to medical retina?
I think the retina is one of the organs in the body where you can actually look at the blood vessels. And looking at that, you can also assess the patient's vascular health. You can see how the patient's doing in terms of their general health. So I really liked that aspect of being able to see the patient and also providing a whole holistic approach to their care. Not only that, when I saw patients with macular degeneration at the start of my career, many years ago, there was very little we could offer in terms of treatment for them. But as the studies have been, as the research has gone on, the trials have gone on, now I feel we can actually make a difference to these patients and improve their quality of life. Because the patients are now living longer, we've got to preserve their vision for a longer time so that they don't end up blind, because already they're old. Along with that, living with blindness is terrible. So as a medical retina specialist, I can make that change in the lives of patients, improve the quality of their vision, quality of life, definitely. And that's really what made me choose medical retina.
Let's start with the basics. What is a retina, and what does a medical retina specialist do?
So the retina is a thin layer of nerve tissue which is present at the back of the eye. So if you think of the eye as a camera, the cornea and the lens is the front of the eye, and the retina is like the film at the back of the eye. As a medical retina specialist, I assess and I treat patients who have disorders of their retina. Some of the most common conditions include things like macular degeneration, diabetes, retinal vein occlusions, to name a few. The amazing thing about the retina is that that's one of the only organs in the body where you can actually look at the blood vessels. So when I examine the retina and assess the blood vessels, I'm also able to assess a patient's cardiovascular health and the overall health of a patient.
I always remember from my training being taught that the retina is almost an extension of the brain, and it's such an important structure, and so many layers, so intricate. So you mentioned age-related macular degeneration, and I know that's a very common condition. So how might somebody present who's developing issues with their retina with age-related macular degeneration?
So age-related macular degeneration is one of the most common causes of blindness, which affect patients mostly over the age of 50 years. As the name suggests, it's called as age-related. The reason why it happens, or the way patients can present with it, is, well, to mention the first thing is patient may not have any symptoms early on. So that's why it's really important that patients between the ages of 40 to 60 go for an annual eye check, maybe every 1 to 2 years, and after the age of 60, definitely annually, especially if you have a family history or of macular degeneration. So there are two types of macular degeneration. There's the dry kind and there's the wet kind. So in macular degeneration, the macula is the part of the retina which is responsible for our central vision, our fine vision. That's how we appreciate color, contrast. So it's really a very important part of our retina. As we grow older, the macula is also the most metabolically active part of the retina. So wear and tear is seen most commonly in the macula. That's where you will see deposits called as drusen, which is one of the signs of wear and tear. This drusen causes a weakness in the layers of the retina, and because of that, new blood vessels can grow from the underlying structures. These blood vessels can leak, and cause fluid buildup or even leakage. So as I mentioned, there are two types, that's the dry and the wet kind. The most common symptoms in both these conditions is they have distortion in their vision, especially their central vision. They can have difficulty in reading, especially in very dim light. They can have difficulty recognizing people's faces. So these are some of the early symptoms that they can have. The dry kind, as I mentioned, is a more gradual onset loss of vision. And as I said, patients may not even know that they have this problem, and it's only picked up when they go for an annual check or when they go to see their optician. The wet macular degeneration is a more aggressive type of condition, and here patients present with a more sudden onset or a rapid loss of vision. The symptoms are pretty much the same where they have loss of central vision, but it's just the way it presents, in that the dry kind is a more slowly progressive, but the wet kind is a more sudden onset.
Okay, so am I right in thinking that somebody may not perceive they have any issues with their vision, but they go along to their annual sight test and their optometrist may be able to detect that maybe by examining them, or there's technology, I believe, that can also pick up these early signs and record them, is that right?
Yes. 20 years ago, most patients with retinal problems, including macular degeneration, we didn't have the tools to assess it accurately, and we didn't really have the treatment. So this is really a very good era to be in terms of eye care. So yes, the optician, first of all, examines their vision. That's the first step. And then we put some dilating drops into the eye, which makes the pupils big, so we can examine the retina at the back of the eye. So the optician looks at the optic nerves and also looks at the macula. So this is kind of the general examination that an optician will be able to do. Along with that, most opticians can now do some scans called as OCT scans, that's optical coherence tomography. The good thing about these scans is that they are non-invasive, and it's not really a radiation or anything. They use light waves, so it's literally like having an ultrasound scan of your eyes. It gives a high definition and a cross-sectional image of the different 10 layers of the retina. So we can assess exactly where the problem is, and the optician can then make that decision whether to refer the patient urgently or in a few weeks, or just tell the patient to monitor and send them home with an annual eye check. This is one of the most common ways or an investigation which is available at most opticians, and I would definitely recommend all patients to see their optician at least once a year.
If we start with the worst case scenario where the opticians detected the so-called wet macular degeneration, where you mentioned there's hemorrhage sometimes and a sudden loss of vision, and they refer the patient in to see you urgently, what is the likely course of treatment that that patient's likely to have?
The good thing is that we have an excellent setup here in Worcester, where all patients whom the optician refer with wet macular degeneration have to be seen within a certain target. So it's normally between 2 to 3 weeks. So these patients are assessed within that time frame. We repeat the examination and we do the scans. And once I make a diagnosis that it is wet macular degeneration, I explain to the patient what the treatment entails. The most common treatment based upon their vision is injections into the eye. So it's what we call as intravitreal injections. The way they work is at the back of the eye, we have something called as a vascular endothelial growth factor. As the name suggests, this is responsible for causing these new blood vessels to grow. So the injections that we are giving are basically anti-VEGF. So they stop the growth of these blood vessels. The main aim of this treatment is to maintain the vision or to stabilize the vision. In very few patients, they may see an improvement, but that is not the main aim. These injections are done very routinely. To start off with, the patients will need one injection every month for about 4 months, and then we repeat the scans, we assess their vision, and based on how they've responded to the treatment, we increase the frequency between the injections. The good thing is that most of our patients do well, and they're at least able to maintain or stabilize the vision that they have with regular injection, regular monitoring, and scans.
That's been a major breakthrough. I mean, when I first worked in the field of ophthalmology, we were seeing patients like this and saying to them, "There's nothing that we can do. When you need registration as certification as a partially sighted or blind person, then you can come and we can do the paperwork. And it was devastating. Now that we have these treatments so readily available, it's been such a massive leap forward. So that's the wet type. Going to the dry type now, tell us about what's available for that or what may become available.
So as I explained, the dry type is a slowly progressive condition. Though there is no active management, there is a lot of nutritional supplements and lifestyle changes which can help to prevent the progression or at least slow down the progression. The first thing would be nutritional supplements. So there was a study done many years ago actually called the ARED study, which is the age-related eye disease study. And that showed that taking these supplements can slow the progression of dry macular degeneration. So these supplements include zinc, copper, vitamin C, vitamin E, and lutein and zeaxanthin. So these are present, and these are the AREDS formulation that you can get off the counter. So taking these medications would definitely help. The second would be lifestyle changes, having a healthy diet, fruits, vegetables, and omega-3 fatty acids. Also, UV protection so that there's no damage from the sun to the macula. Smoking is one of the risk factors. So definitely, if you're a smoker, do think of quitting smoking. Exercise helps because it improves your overall health and also improves the circulation. The other option is the way they can assess is to self-monitor the vision, because patients who have dry macular degeneration are at a risk of the dry kind changing to the wet kind. So there is something called as an AMSLR chart that patients can get from the web, really, from the internet. So the AMSLR chart, if they can monitor their vision with that at least once a week, it's a small chart that they can put on their refrigerator or something like that. And they assess it by closing each eye. And they look for any signs of new distortion. So any new changes that they notice, they need to get themselves checked either by their optician. There are other treatments in the pipeline. One of it is called as photobiomodulation, which is light therapy essentially. So this has been approved by the FDA in America, and there has been many studies on it. And one of the most important one is the light study. So what this shows is that in patients with early and intermediate dry macular degeneration, light therapy is used. There are very different wavelengths, and it targets the macula. The rationale behind is that partly macular degeneration is driven by inflammation. So this light waves stimulates the mitochondria, which are essentially the energy houses in the macula, and it helps to get rid of this drusen or debris a bit more quicker. And the studies have actually shown quite good results in the sense that patients were able to improve their vision by a few lines, though not dramatically, but there has been an improvement, and patients have definitely been able to maintain their vision.
It's one of those things, if you've witnessed a friend or family member develop this, it is so disabling and life-changing, and anything that you can do, the lifestyle changes which are so important, but this is adding an extra research evidence-based treatment that might help a lot of people to not end up having lots of injections in their eyes potentially. Moving away from macular degeneration now into diabetes. So this is a very large area in terms of your workload, I'm sure, because diabetes being so prevalent. So how can diabetes affect the retina? What kind of things do you see there?
So as diabetes affects all organs in the body, including the eye, so what it does is it normally affects the small blood vessels in the retina, and it causes a condition called as diabetic retinopathy. All patients about the age of 12 years in the UK are offered annual eye screening. So it's very, very important that patients who are diabetic attend these annual eye screening, because that's where these things are picked up and then appropriately referred. Because as I said, most of the patients with diabetic eye condition may not know that they have they may not have any symptoms, and by the time they present it may even be too late, because the retinal cells are nerve cells, and once they are damaged they don't regenerate. So in the early stages of diabetes, which affects the eye, we can see some hemorrhages in the eye. In the much later stages, there can be swelling in the macula. And we can also have reduced blood supply to the macula, leading to macular ischemia because of lack of blood supply. Again, the mechanism in the diabetes also can be a little bit similar to what happens in macular degeneration, in that fluid can build up in the macula and affect the vision. In very advanced cases, because the blood supply to the retina is affected, new blood vessels can grow. Now, these blood vessels are very fragile and they can leak, and that causes more loss of vision. And in very advanced cases, it can even cause retinal detachment, which may require surgery.
As you say, I think one of the scariest things for people who have diabetes for a very long time is that they can have a lot of changes before they're even aware of anything, which is why the screening is so important. Managing your diabetes and your blood pressure and your blood sugar is so central to the complications that you get. And going back to what you said at the beginning about the back of the eye being a mirror into, or a window into, the general health, whatever is going on there is also going on everywhere else. It's a really useful way of gauging how well or poorly controlled a diabetic is when we see their eye disease. Moving away now to vascular occlusion. So that's something that we see quite a lot of as well. Talk to us about that.
So the blood vessels at the back of the eye can sometimes have a blockage. Again, the risk factors for this are high blood pressure, uncontrolled blood sugars, cholesterol. So these are the most common causes of vein occlusions. These vein occlusions could be complete. That is, if the central retinal vessel is blocked, then you can have complete loss of vision, or it could just affect a part of the retina in what we call as a hemiretinal vein occlusion or a branch retinal vein occlusion. In very early cases, if the clot or the thrombus has just caused a blockage in a small part of the retina, we just monitor the patient, tell them to improve their cardiovascular risk factors, and then we just monitor them. But in very advanced cases, or if there is complete blockage of the retina, it's usually associated with macular edema. Now, how we need to think about this is the retina has been deprived of blood supply. So it's very ischemic or oxygen deprived. And because of this, you can have swelling in the macula called as macular edema. And also there can be formation of new blood vessels in the retina because the retina is basically lacking oxygen.
Just like the diabetic.
Just like the diabetes, yes. The treatment for it, the first and foremost treatment is to improve your cardiovascular health. So it's blood sugar monitoring, blood pressure monitoring, stricter control over cholesterol and other cardiovascular risk factors. The treatment for macular edema is in the form of injections into the eye, the same anti-VEGF injections. There are many treatment protocols that we follow. So we give, again, the monthly injections of anti-VEGF. There is also the option of giving a steroid implant into the eye called as Ozurdex. So that's another option that is present for patients with vein occlusions. We also have to monitor these patients because sometimes they can develop these abnormal blood vessels, which can leak and cause further loss of vision. So in such cases, we offer the patients laser treatment. Essentially, we are doing the laser to reduce the oxygen requirement of the retina so that we can save the central vision.
And there are some patients as well, aren't there, that become so ischemic that new blood vessels start to grow at the front of the eye and then they develop glaucoma, their pressures go up, and that can be a very difficult situation to manage. Earlier in my career, it was much commoner to have to remove somebody's eye because it was blind and painful from uncontrolled neovascular glaucoma, as we would call it, and that rarely seems to be the case now. So although we're not always able to save sight or to improve sight, at least we can prevent a blind painful eye, which is really good. The last condition that I thought it would be important to talk about is giant cell arteritis, because that's obviously potentially catastrophic, and that's, again, cardiovascular. Tell us about that and how patients might present with that.
So joint cell arteritis is really a devastating condition, and it's one of the few ophthalmic emergencies that we need to act on straight away. So most of these patients are elderly patients who already have other cardiovascular risk factors. So the most common symptoms in which these patients present are headaches, especially in the temporal area, any tenderness of their scalp region. They can have jaw claudication, that is pain when they chew food, which presents as jaw claudication. So what we do in these patients, or if these patients present to their GP or the optician, they are straight away referred to us, especially if they have any vision symptoms as well. So these patients are assessed on the same day most of the time, and we examine the patient, we check for their pupils, we check for their eye pressures, we also examine to see where the tenderness is, and of course we take a detailed history from the patient to start with. We ask for any risk factors that they may have. For example, some rheumatological conditions can predispose these patients to have giant cell arthritis. And then we examine them, we look at the retina. The most common part of the eye which is affected in giant cell arthritis is the optic nerves. So the optic nerve is something which carries signals from the eye to the brain and back. And in giant cell arthritis, the blood supply to that optic nerve is cut off. Why it's such an emergency is because the loss of vision is irreversible. And not only irreversible, if we don't act on it immediately, it can also cause loss of vision in the other eye. So it's quite catastrophic. So what we do is we, first of all, once we made the diagnosis of giant cell arthritis based on all these symptoms and signs, we do some blood tests for these patients. We look for their inflammatory markers. We look for platelets. And then depending on that, we also now are able to do an ultrasound scan where we scan arteries here. So it's non-invasive and it gives us a lot of added information, because the definitive treatment or the definitive way we can diagnose these patients is by doing a biopsy. But before that, we start these patients with steroid tablets, and we also refer them to the rheumatologist, because the treatment of this condition is ongoing. It's not that we just see them on one day and discharge them. So we continue to monitor them after that. In terms of visual outcome itself, it depends upon how bad the inflammation is, but at least we are able to preserve whatever vision they are left with, and with timely treatment and management, we can prevent loss of vision in the other eye as well.
Yes, it's one of those conditions that we dread seeing, and because sometimes the symptoms can be a little bit vague, teasing it out because we don't want to be putting people on high dose steroids unnecessarily, but sometimes we just start it, do all the tests, and then take people off if we're really concerned about it. I think double vision is another symptom that sometimes it can present with. Yes, and there's a condition of generally older people. In terms of how you see the future and what the emerging therapies are, what's your view of what the next 10 years is likely to reveal to us?
I think it's quite interesting because there's so much of research going into ophthalmology, especially medical retina, and there's so many trials. So we're just waiting on the results of so many trials. Most of the trials are on patients with macular degeneration. So one of them is, as I mentioned, the treatment of wet macular degeneration is in the form of injections into the eye. A lot of trial is going into, instead of having these repeated injections, the patients can have a port put into the eye, and then that port it's like a refillable syringe. So that port carries about 6 months worth of injection, which just keeps going into the eye, and then it needs to be replenished after 6 months. So that's something that's going on in trial, and it's quite exciting because patients don't have to have their monthly injections. We're also looking at many newer generation anti-VEGF injections. The aim of this is to improve the efficacy so that patients don't require monthly injections, and we're able to increase the frequency in between these injections. That's definitely handy, so that because it's not nice having injections in the eye every month. The other thing is on patients with dry macular degeneration. There is a lot of research going on in that. There are actually two very new trials. One of them is injections into the eye in patients with geographic atrophy, that is very advanced macular degeneration. Because most of the time, as I mentioned, we are not able to offer any treatment to them, any active treatment. So there is the option of having injections, and they're looking into how it can improve the atrophy. The other one is having an implant. It's called as the Prima implant. It's currently being trialed. Actually, Moorfields Eye Hospital in London was one of the centers for it. So they put a small chip into the macula, and the patients have to wear special glasses. It's almost like a stimulation, and that has helped patients to have some functioning vision, though not complete vision. These are kind of the new research that's going on into medical retina and ophthalmology. We aim to improve the quality of patients who are living with sight loss, because it's really quite devastating for these patients. And I definitely think more trials need to be done on this.
I'd be interested to hear what you think, because you have alluded to, in the various things that we've talked about, lifestyle factors, controlling sugar, controlling blood pressure, exercise, cholesterol. My feeling for all the years that I've been in practice and have my interest in well-being, that so much of this could potentially be prevented. So if people in their 30s, 40s and beyond actually start to eat well, avoid ultra-processed foods, exercise, get quality sleep, manage stress, all of those really important pillars. My theory is that maybe we can actually prevent people getting as far as having to sit in front of you and have a needle stuck into their eye. And there's not a much bigger incentive than that. Do you agree? What do you feel is the role of lifestyle in all of these diseases?
Yes, absolutely. I think there has been good evidence as well. It's just not, that, we're just saying it, that healthier lifestyle, having green leafy vegetables like spinach, kale, because these have antioxidants. They also have lutein, zeaxanthin, which help the macula. Good exercise improves cardiovascular blood flow, and that definitely helps with our vision. As I said, in all this, it's before we come to having the condition. If we have ways to prevent the condition, and it's definitely useful. And not only that, also going for regular eye checks, especially having a baseline. And if you have any family history or anything that you're concerned of, just instead of sitting on it thinking, I'll go when I get some problem, I can see all right, what's the whole point? So just to not put it off. So early detection is really the key, and even better, prevention is even better than that.
Akshatha, thank you so much for talking to me. I think it's been a really interesting conversation. I've learned a lot, and I hope those people watching our podcast will benefit from your wisdom. So thank you. I hope you've enjoyed listening to today's podcast. If you have any questions for Akshatha, then please leave them in the comments below. And please like and subscribe, share with your friends and anyone you think might be interested in eye health. We look forward to seeing you next month.